through full review and approval by AASLD governing board. The other one is on nutrition, sarcopenia, and frailty. So for years, we've known about liver biopsy as being the standard modality of assessing inflammation and, of course, fibrosis. And then over time, we've evolved to learn about serum biomarkers. And then there are also non-invasive ultrasound guided tools to assess the severity of fibrosis. Now, with regard to this NILDA guideline, and this applies actually to the other guideline on sarcopenia, AASLD commissioned a diverse group of experts from various disciplines in the field of adult and pediatric liver disease to go over the literature carefully and come up with a guideline. So they were charged with looking at blood-based modalities, imaging-based modalities as non-invasive modalities, and then also they were charged to looking at the role of NILDA in patients with clinically significant portal hypertension. They went through the published literature from 1988 to 2021, and then answered several what we call Pico questions. Pico stands for patient population. I stands for intervention. In this case, a non-invasive test. Comparison would be the liver biopsy and the outcomes in terms of how good they are in assessing inflammation and fibrosis. So the first question is of using NILDA. And then the group just came up with, and again, obviously this is a position of AASLD, and it's recommends that blood and imaging-based NILDA can be used as initial tests to detect significant to advanced fibrosis and cirrhosis. So there's a paradigm shift in that at one time it was said, well, we had to do a liver biopsy, but now we're saying that prior to considering a liver biopsy to assess fibrosis staging, we could go with blood and imaging-based non-invasive liver disease assessment tools. Now, there are blood-based non-invasive liver disease assessment tools for fibrosis and steatosis. There are several of those out there, and algorithms have been designed based on blood-based testing, and then imaging-based testing would be assessment of fibrosis through, say, FibroScan or ultrasound elastography, and then for steatosis, it's CAP or controlled attenuated parameter, and then there are MRI-based tools for assessing liver stiffness and also assessing steatosis. While we have a number of these tools, there are limitations that we all should appreciate. For blood-based tools, certain features may alter the reliability of these non-invasive tests. Splenectomy, hepatic inflammation, if it's severe, may contribute to increased stiffness. Thrombocytopenia from other conditions may impact on scores such as APRI score. Similarly, active alcohol use, chronic kidney disease, hemolysis, Gilbert syndrome can all alter the readings of these non-invasive tests. And then if you look at imaging-based modalities, the limitations are obesity, ascites, obstructive jaundice, heart failure, etc. So we need to keep these factors in mind when you assess these non-invasive tests. So if you were to look at the guidance statement with regard to blood-based NILDA, suggests that in adult patients with chronic liver disease, AASLD recommends using simple and readily available blood-based tests over complex and expensive blood testing for the initial detection of significant to advanced fibrosis cirrhosis. Now, in patients with chronic hepatitis C with viremia who require fibrosis staging, the guidance document recommends using simple, cost-effective, and readily available blood-based tests such as APRI, AST to platelet ratio index, or FIB4 or fibrosis 4. You can readily calculate these by calculators that are available online. You don't need a whole lot of testing. For FIB4, you need AST, ALT, platelet count, and the age. For APRI, you need the AST and the platelet count. And you can readily do these. Now in our clinical notes, we are having these as smart phrases. You can't close the note until you have the smart phrases populated. You can readily calculate APRI and FIB4. Now in patients with NAFLD, similarly, you could use APRI, FIB4, or an additional NAFLD fibrosis score for the detection of advanced fibrosis. There is moderate quality of evidence for these recommendations. Well, the recommendation is strong. Now, what about combination testing to enhance the reliability of assessing fibrosis? In patients with HCV, the guidance statement suggests the use of combination of APRI and fiber test over using either test alone for detecting significant fibrosis. In patients with NAFLD, guidance statement suggests using combination of NASH fibrosis score and FIB4 in identifying advanced fibrosis over a single test. Now, what about serial testing? The guidance statement suggests not to use blood-based NILDA to follow progression, stability, or regression in histologic stage for HBV and HCV following antiviral therapy. That is particularly in patients who have virus suppressed on hepatitis B therapy and those who have eradication of hepatitis C over time, as their reliability in these tests in following progression, stability, or particularly regression in histologic stage. And the answer to that is no, we are not at a stage where we can reliably use these tests to assess for regression in histologic stage. Now, what about imaging-based testing? Ultrasound elastography or MRI elastography. Well, AASLD recommends using available imaging-guided NILDA targeting liver stiffness for the detection of significant advanced fibrosis and also for cirrhosis, given their good to excellent diagnostic accuracy. Now, what about superiority of one versus another imaging modality detecting significant fibrosis? In patients with chronic Hep B and Hep C, ultrasound-based elastography, be it FibroScan or ultrasound-based elastography, they have acceptable diagnostic accuracy for detecting significant or advanced fibrosis. Similarly, in NAFLD, ultrasound-based elastography of comparable diagnostic accuracy for detecting advanced fibrosis. However, MRE is superior to ultrasound-based technologies for detecting significant or advanced fibrosis. So you start out with ultrasound-based studies, and if you want to enhance the detection capability reliably, you can go with MR elastography. What do? Do you go first with blood-based assessment or imaging assessment? Well, this, of course, is a challenging area. The document suggests that the choice of blood-based versus imaging-based NILDA should be based on local expertise, test availability, and of course, the cost of test. Now, what about combination testing? Addition of blood-based testing to ultrasound-based elastography improves diagnostic accuracy in hepatitis C. Interesting, though, based on what's out there in the literature, for hepatitis B, the addition of blood-based NILDA to ultrasound-based elastography does not improve diagnostic accuracy for detecting significant fibrosis. In patients with NAFLD, the sequential combination of ultrasound-based elastography to blood-based NILDA may improve diagnostic accuracy. So there's some variability in the combination testing and their ability to enhance diagnostic accuracy in the various disease categories. And as time goes by, we'll see more and more data evolve to help us guide as to whether we can use combination modalities in all disease states. Now I want to switch gears and go to nutrition, sarcopenia, and frailty. Now, some fundamental definitions are important. Malnutrition is a nutrition-related disorder that results from lack of intake or uptake of nutrition that leads to altered body composition, where there's decreased fat-free mass and body cell mass. Now, sarcopenia is a generalized reduction in muscle mass and function due to aging, that's primary sarcopenia, or due to acute or chronic illness, such as secondary sarcopenia, and the chronic illnesses here include chronic liver disease. You have to understand there's a little bit of an overlap between malnutrition, sarcopenia, and frailty. And frailty is a loss of functional, cognitive, and physiologic reserve, leading to a vulnerable state. And it may be considered a form of nutrition-related disorder. And then there's deconditioning that, again, has an overlap with malnutrition and frailty. Now, as I pointed out, there's an interplay between these various defined conditions, but what are the consequences of sarcopenia and cirrhosis? There's an increased rate of encephalopathy, and where there is an asterisk, it indicates that it's supported by strong evidence. There's a decreased overall survival, decreased quality of life, and in HCC, there's decreased survival and increase in treatment-related complications. In liver transplant recipients, there's increased waitlist mortality, a high rate of peri-liver transplant complications, particularly infections. There's decreased post-liver transplant survival. And there's an entity of sarcopenia obesity that may evolve in liver transplant recipients, particularly who are on corticosteroids, where they appear to be obese, but they are sarcopenic by way of decreased muscle mass. Now, there are various assessment modalities that clinical features and certain tools, such as hand grip strength assessment, 6-minute walk test. There's a Freed frailty index, and then there's a short physical performance battery assessment. And you can readily get these tools by going online. And then there are quantitative investigations, such as triceps skin fold thickness assessment, MRI tools, CT scan assessment. And CT scan is perhaps the gold standard, whereas MRI assessment of muscle mass follows it. And then you can use DEXA scan or bioelectrical impedance analysis as a tool for assessing sarcopenia. Now, the guidance statements are such that all patients with cirrhosis should be assessed for frailty with a standardized tool, both at baseline and longitudinal. This is critical. As physicians and patients and caregivers, we focus on management of ascites, management of hepatic encephalopathy, management of varices, but often neglected is frailty and a sarcopenia assessment. These patients' cirrhosis should be counseled on the risk and adverse clinical consequences of frailty, regardless of their frailty status at baseline. Now, there are several tools. There's no data to suggest that one tool is better than the other, but you need to use a tool in clinical setting to systematically assess frailty and sarcopenia in all patients with cirrhosis. And it's really critical. We do have several tools that we employ in our clinical practice, primarily the 6-minute walk test, the hand grip assessment, and so on. Now, these patients and the caregivers should receive education, motivation, and behavioral skill support to reduce the risk of developing these complications, which, as I pointed out, can turn out to be quite detrimental, particularly in the context of liver transplantation. Now, it's recommended that in patients with well-compensated disease, that at least annually assess their frailty status and sarcopenia status. But if they have decompensated cirrhosis, ideally one should assess their frailty status, particularly every 8 to 12 weeks, so that you can then pursue interventions. Now, it requires a multidisciplinary team. It should consist of the patient's primary care provider, the gastroenterologist, hepatologist. We need a dietitian. They are in short supply and they are overwhelmed. Nevertheless, we need a dietitian, need a certified exercise physiologist, or a physical therapist, and a health behavior specialist if there is a concurrent mental health condition. And it's critical that we approach this with a team-based approach. Now, TIPS placement for standard indications, ascites, particularly acute variceal bleed, may offer an indirect benefit of improving muscle mass. Once they have a TIPS placed for ascites, they may be able to eat better. So that may help in nutritional enhancement. Calories, the need for calories should be personalized to the patient. In non-obese patients, target of at least 35 kilocalories per kilogram body weight a day. In obese, non-hospitalized, clinically stable individuals, use of calorie target stratified by BMI 25 to 35 kilocalories per kilogram per day. For individuals with BMI of 30 to 40, and then 20 to 25 kilocalories per kilogram per day for individuals BMI greater than or equal 30. Now, you have to keep in mind that the body weight should be their ideal dry body weight, in that if they have ascites, you have to make a certain adjustment for ascites, and there are ways by which you can make adjustment for weight if they have significant ascites. Now, this is critical. The recommended daily protein intake for adults with cirrhosis, 1.2 to 1.5 grams per kilogram ideal body weight per day. If they're critically ill, a target of 1.2 to 2 grams per kilogram ideal body weight per day is recommended. Now, when patients have encephalopathy, they get this information saying, oh, my doctor said, or someone said, I have to restrict protein. That is not correct. Protein intake should not be restricted in patients with hepatic encephalopathy. The nutritional status overrides the management of encephalopathy, and it's important that they have adequate protein intake. Now, the next principle that I advise my patients is that the fasting time should be minimized with a maximum interval of 3 to 4 hours between nutritional intake while awake. To minimize nocturnal fasting time, there should be an early breakfast recommended, and a late evening snack is very critical. So early breakfast and a late evening snack. Now, for those who do not meet dietary intake requirements with oral intake, enteral nutritional supplementation, here the guidance document says may be considered to achieve targets. I say should be considered. Not uncommon, you go on the floors and you ask the patients, the caregivers, they say, oh, I'm eating okay. Well, they're not eating okay. If you're eating okay, you should not be so sarcopenic. So I really push for an enteral tube feeding. And of course, when you do that, you obviously want to be ensured that they do not aspirate, so there should be aspiration precautions. Previous detection of varices or variceal bleeding are not an absolute contraindication for the placement of an enteral tube. I get that question often. So it's critical that nutrition, attention to nutrition, overrides these other factors. So if you look at an algorithm for screening, assessment, and management of malnutrition, frailty, and sarcopenia, so patient cirrhosis, the document suggests that at baseline, the cirrhotics be screened for malnutrition, assessed for frailty and sarcopenia. Both are normal. Still educate them and the caregivers about adverse outcomes in such situations, and they should do everything possible to prevent them. And if they do have frailty or sarcopenia, should really address them through various management strategies, which I'll go over here. Now, if you were to look at diagnostic tools, there are clinical questions that you should seek out. Look at the Karnofsky Performance Scale. Questions about activities of daily living. Physical examination can give you some ideas. You can look at their muscle status. Is there muscle wasting? Are they using a walking aid? Are they able to stand up from the chair independently, or are they able to get off the examination table independently? Fair number of patients who come for a liver transplant evaluation, they cannot get on the table, or once on the table, they cannot get off the table. So clearly, that tells you that they're not well. Their objective measures, I talked about CT scan, you can do a frailty index, hand grip strength, etc. And then the management tools, liver-specific management of disease etiology, management of ascites, management of hepatic encephalopathy become important. Physical activity important. I talked about nutrition and in terms of protein that they need. And then there are specific interventions that can be considered. In men, you can do a testosterone level. If it's low, testosterone replacement may be ideal, except in certain situations, such as patients who have a HCC. And then, of course, diabetes control is critical. So this is an overview of how we should handle malnutrition, frailty, and sarcopenia in patients with cirrhosis. This stage I'll end. I thank you very much for your attention, and then we'll go later on to discuss further during the question and answer period. Thank you. I guess the next one speaker would be Cynthia. Go ahead.
It's Chris.
Yeah.
And thank you for the great questions in the chat, and they'll all be addressed at the end.
Great, thank you so much. So I've been asked to speak about Wilson disease and palliative care. And so what I'd like to do here is kind of go quickly through some updated key points that would be of interest to patients with regard to Wilson disease, and touch on the concept of palliative care, which I think is very important for our patients living with liver disease. So I have no relevant disclosures related to this talk. So I was very grateful to Dr. Shilsky, who is leading the writing group for diagnosis and treatment of Wilson disease, and Dr. Fasiha Kanwal, who is leading the writing group on palliative care, for sharing their information with me. These are still in development, and final versions will be released shortly. So first of all, with Wilson disease, it is now a guidance and not a guideline. And that's important for patients because guidelines are limited by very specific protocols, and you have to have a level of evidence that is considered acceptable and a level of critical review that is considered necessary before something can be labeled a guideline. A guidance allows us to be a little bit more flexible in terms of using new criteria for making recommendations. So there's something called the Leipzig Score, which has been associated with describing prognosis in Wilson disease. This has been added for reference. And there are some new changes with regard to diagnosis that I'll talk about here shortly. There are some additions to the guidelines that I would encourage patients to look for. These include more expansion in the pathology section where we define what Wilson disease is. There are some key points with regard to neurology, psychiatry, and dietary sections that I think are important, particularly with regard to management of depression, anxiety, and other neurobehavioral problems that are often unrecognized in patients with Wilson disease. There's a new definition of what is asymptomatic and what is symptomatic, and many patients, may be symptomatic, but their symptoms may not be associated with Wilson disease. And there's a new recognition, and this is very important for patients, that acute liver injury, which would normally be also called fulminant hepatic failure or acute liver failure due to Wilson disease, might still be treatable. And there's also new therapies regarding treatment failure. So let me look at this. Let me spend a couple of minutes on this slide because I think it's very clear in explaining how we walk through the diagnostic cascade. So first and foremost, if a patient has a ceruloplasmin that is between 10 and 20, or has a ceruloplasmin more than 20, and the 24-hour urine copper is 1 to 2 times elevated, or more than 2 times the upper limit of normal, the recommendation for patients who present with liver disease is to start with a liver biopsy and to measure the liver copper content. The liver copper content is diagnostic for Wilson disease in that normal liver copper is going to be less than 50 micrograms per gram dry weight. In patients who have very high liver coppers, more than 5 times the upper limit of normal, we can make the diagnosis of Wilson disease. And the role of genetic testing is really of great importance to patients. And we now believe that genetic testing is important for patients with regard to family screening, but it remains very expensive and not always covered by insurance. In contrast to other genetic diseases that are monogenic diseases with only a few mutations causing disease, Wilson disease and alpha-1 antitrypsin deficiency, which I'm not going to talk about today, are diseases where you have a large number of different mutations that could be potentially leading to the disease. So one of the challenges for patients is how can you be sure that your doctor has made the diagnosis of Wilson disease correctly? There are a lot of resources, but I would suggest that knowing what is the liver copper content, was a liver copper measured at the time of the biopsy, and what did it show? I would encourage patients to say, I would like to know what the liver copper content is. And if it is more than 250 micrograms per gram dry weight, you can be sure that that is likely to be Wilson disease, although there are some conditions where rarely, such as PBC or PSC, where because copper is excreted through the liver, through the bile ducts, bile duct diseases can lead to elevated copper, but usually not to this degree. So in summary, for the diagnosis, we look at the ceruloplasmin level, the 24-hour total copper, and hepatic copper content. So here's a checklist for dealing with gray areas. And this is where I think it's important for patients to empower themselves to try and collect this information. Was an adequate liver copper measurement done? Was the 24-hour urine copper collected for total copper? Was the serum ceruloplasmin truly low or borderline low, where certain situations like inflammation can lead to an elevated ceruloplasmin? And how well was the genetic testing done, if appropriate? So where do we want to empower ourselves as patients to make sure that these things are done correctly? Well, let's have a ceruloplasmin level measured more than once. Let's make sure the 24-hour urine copper was collected properly, and let's make sure that the liver copper was measured correctly. So this is a very important slide because it's really telling us what are the 3 different phases of the disease: prevention, treatment, and rescue. So in the earlier stage of the disease, where there's not much in the way of liver damage, We're looking for asymptomatic patients who are going to be more likely represented. We are looking for other mild markers of liver disease, such as elevated liver enzymes, and symptoms may be nonspecific. Once a patient has progressed to developing cirrhosis, we need to know that about 1 out of 20 up to 1 out of 20 patients will develop liver failure and may need to be considered for liver transplant urgently. And then finally, the complications of liver disease are no different in Wilson disease than any other disease. So we need better definitions, and we're working towards this in terms of treatment failure. There's a new scoring system called the New Wilson Index, and that is a prognostic scoring system along with the Leipzig criteria, and essentially assigns points to various blood tests, and the degree of derangement in the blood test or abnormality of the blood test gives a certain number of points, and the higher the number of points, the more closely the patient needs to be monitored. So in summary, the Wilson disease guidance that I would like to highlight is genetic testing should be performed mainly for family screening, not for diagnosis. The new guideline will have better definition of treatment failure. At what point are chelators not working, and at what point is zinc no longer an option? There are going to be new recommendations regarding dose adjustment with pregnancy, and there's going to be a greater emphasis on including neurologists, psychologists, and psychiatrists earlier in evaluation of patients because of the recognition that depression and other neurobehavioral issues may be poorly recognized. There are new treatment recommendations forthcoming for tetrathiomolybdate and trientine for maintenance, and there are new dietary copper restrictions coming, suggesting that you should be much more strict early in the disease, but you could be more liberal once the disease is better controlled. Let me switch gears now and talk about palliative care for patients with cirrhosis. And again, I thank Dr. Fasiha Kanwal, who's leading this group, for providing me the information I'm presenting today. So it is very important for patients to understand the difference between hospice, palliative care, and different types of levels of intensity of care that patients are afforded. Regrettably, we know that patients with cirrhosis still have a very high risk of mortality and have an unpredictable illness trajectory. Once patients get to a point where they have decompensated liver disease, any precipitant can easily lead to a catastrophic situation where the patient is in the intensive care unit with a very high MELD score and looking at a very life-threatening condition. All-cause mortality in patients with cirrhosis, and we're all working hard to make this better, but maybe as high as 46% at 5 years for all-cause, and cumulative all-cause mortality at 40% at 4 years. So clearly, once the patient has cirrhosis, I think it's important that they're monitored and cared for by experts. Palliative care is defined as a multidisciplinary specialized medical care that includes and addresses physical, spiritual, and psychosocial needs in patients with serious illness. We're increasingly recognize this as important for patients with cirrhosis. So what are the different aspects of the care? There are the structures and processes of care that we're very comfortable with as doctors, and that includes physical aspects of care. As you go further down this list of boxes, I think we're less and less able, because training is still somewhat catching up to these needs that our patients face: psychological and psychiatric aspects, social aspects, spiritual, religious, and existential aspects, cultural aspects, ethical and legal aspects, and dealing with the importance of caregiver support. So it's very important to recognize that you can have specialty care that's palliative, primary care that's palliative, and that is not the same as hospice. And so here we are talking about care delivered by specialists with advanced skills, with board certification, preferably in palliative care, physicians or other allied health workers. Primary care would be looking at alignment with principles of palliative care, but can be delivered by any medical professional. This is different from advanced care planning, which is a component of palliative care that involves identifying surrogate decision makers, illness education, and prognostic disclosure, documenting the goals for medical and end-of-life care through advance directive. Hospice care is very focused on end-of-life care, focused on comfort, and different than palliative care in that here we're focusing exclusively on comfort for the patient and pain management, for example, dealing with stress and anxiety, improving breathing, improving comfort, rather than disease-directed treatment that includes only individuals with life expectancy measured in months. So the guidance says palliative care can be provided to patients with decompensated cirrhosis at any stage of their illness. And the word palliative care does not mean that we are no longer interested in a cure. It just means that we are looking for an evaluation for unmet needs, both by primary and specialty caregivers. We as hepatologists, given that we do not have sufficient palliative care providers in our specialty, need to play a central role, not only because we have the best knowledge with regard to which patients have a better prognosis or a prognosis that could be improved with liver transplantation, but also because we are the ones with the greatest long-term relationship with the patient. Disease-directed care, such as transplantation and evaluation and listing, again, does not preclude palliative care. So this advanced care process is an iterative process that starts when a patient has a diagnosis of cirrhosis and should occur prior to an urgent situation where the liver is failing and decision-making capacity is not quite what it was. Hospice, again, is different than palliative care due to the poor prognosis at present of patients with very advanced decompensated cirrhosis. Many patients with decompensated cirrhosis may qualify for hospice benefits, which could be of great help to patients and caregivers. But it's important to recognize, again, that caregiver support should be provided across the trajectory of the disease, critically important in later stages of the disease. I'm going to finish by talking of end-of-life care. This addresses palliative needs at the end of life and creates plan and provide education about possible scenarios. What do we do if the patient develops a life-threatening infection? Do we have clear direction about how do we manage bleeding? How do we manage hepatic encephalopathy? Hospice is a patient and caregiver-centered option for end-of-life care, underutilized by patients. And so when do we consider this? When should you as a caregiver or somebody yourself who is awaiting liver transplantation and hopefully will get one, but at what point do you say, is palliative care important to keep in my care team? Well, if the MELD score is climbing and the child PU assessment is very high, maybe that's a patient where we know we have good prognostic information about long-term outcomes. And you may want to entertain the discussion about hospice. And this may also help caregivers in helping patients and their loved ones in terms of decision-making at key junctures, such as pain medication use, etc. So the key takeaway is palliative care is a multidisciplinary process that addresses psychosocial, spiritual, and physical needs. We believe it's underutilized in patients with decompensated liver disease. We encourage all members of the care team to provide palliative care, to play a role in palliative care, and to address the symptomatic, spiritual, and psychosocial needs of patients and their caregivers. You know, when we're seeing patients in the ICU with tubes coming out of them and we're looking at their potassium levels and whether they need to be intubated and whatnot, we're not thinking about these things, which may be of much greater importance to the patient than to us trying to solve our immediate problem. And future research is needed to identify optimal approaches to train our staff in primary skills for palliative care, engagement of specialty palliative care, and recognize that it does not mean hospice care and palliative. It could be an adjunct to therapy that's still aimed at a cure. Thank you so much.
Good morning, everybody. It's really a pleasure to be here today talking to you in this inaugural ASLD activity geared towards patients and caregivers, talking to you about the new guidance document on PSC and cholangiocarcinoma. The members of the writing group are listed below, and they were co-chaired by Chris Bolus and David Assis. I'm Cynthia Levy. I'm a hepatologist at the University of Miami, and I'm a member of the ASLD Practice Guidelines Committee. These are my disclosures, but the most important one is this one. As was mentioned before, these recommendations are still preliminary and have not yet been approved by the ASLD Governing Board. All right, let's start with PSC. As you know, primary sclerosing cholangitis is a rare disease. In its classic form, it affects large ducts, causing the characteristic strictures and dilatations that we can find in the cholangiogram. In a minority of patients, these will not be visible and will have what we call the variants. They can be the small duct PSC or an overlap with autoimmune hepatitis. The disease affects both males and females, but predominantly males of any age. And it's frequently associated with inflammatory bowel disease, more commonly ulcerative colitis in about 80% of the cases, but also Crohn's disease and indeterminate colitis. The disease often presents with elevated liver enzymes in a cholestatic pattern, meaning alkaline phosphatase or GGT will be elevated, and half of the patients are symptomatic at the time of initial presentation. These symptoms can be abdominal pain, itching, tiredness, jaundice, or manifestations of end-stage liver disease. So what do the guidance document, what does the guidance document tell us about diagnosis of PSC? And I want to make a remark here, as Chris mentioned earlier, there's a difference between guideline and guidance document. Those are guidance statements from a guidance document. So in patients with suspected PSC, a high quality MRI-MRCP should be obtained to look for the diagnostic features of PSC. ERCP, which is the endoscopic retrograde cholangiopancreatogram, should be avoided as a diagnostic test for PSC, right? We try to do it non-invasively. Now, if that initial MRI-MRCP is not diagnostic, we still recommend a repeat MRI-MRCP done with 3D MRCP reconstruction at an experienced center, right? And this MRI-MRCP will give us a lot of information. We should obtain T1 and T2 weighted images to evaluate the parenchyma as well. A liver biopsy should not be recommended routinely for patients with typical findings in the MRI-MRCP. It should be reserved for patients in whom we suspect that small duct variant or an overlap with autoimmune hepatitis, but should certainly not be the first step in your diagnosis for PSC. Patients with small duct PSC should be monitored for progression to large duct PSC. So the guidance document doesn't exactly specify how often this should be done. I think in our practices, we do maybe every 2-3 years get an MRI-MRCP for patients with small duct, because we know that a quarter of them will progress to large duct disease over a median of 7 years. As far as natural history and outcomes, a patient with PSC can experience one, a few, or all of the outcomes listed here: progression to biliary cirrhosis and complications of portal hypertension, biliary strictures with high-grade strictures occurring in about half of the patients, and that can be early at the time of diagnosis or later in the course of the disease, always bringing the concern about malignancy, even though the vast majority, 3/4 of these lesions, are benign. Bacterial cholangitis, which is an infection in the biliary tree, and unfortunately a high burden of malignancies that occur in this disease. So there is an increased risk for cholangiocarcinoma, colon cancer, gallbladder cancer, and liver cancer. So how does our guidance document address these issues? Well, first, as far as management, with the caveat that, as we know, there is no FDA-approved therapy for PSC. It is new in this guidance document that they make a recommendation regarding pharmacological treatment. They state that in patients with persistently elevated alkaline phosphatase or GGT, ursodiol in doses of 17 to 23 milligrams kilo day can be considered for 6 months. Now, they say 6 months because the plan is to continue monitoring and depend on the effect that we observe in the labs or in the clinical features. This can be extended, of course, but if the patient is not responding, then it should be appropriate to consider discontinuing that. There is, at this time, insufficient evidence to recommend oral vancomycin. We understand its use. There is a lot of open label data in the pediatric population. There is promising, but in adults, the randomized control data is insufficient, and therefore there was no evidence base to recommend its use at this time outside of a clinical trial. For patients with combined PSC and autoimmune hepatitis, immunosuppressants are recommended, and the practitioner is directed to the guidelines for autoimmune hepatitis, which were published a year or two ago by AASLD, into how to manage the immunosuppression. Now, in the setting of bacterial cholangitis, it's recommended to treat with antibiotics and then consider an MRCP to look for a relevant stricture. The ERCP, or the invasive test, will be reserved for cases with inadequate response to antibiotics. Now, what about cancer and surveillance? Well, through surveillance, we can prevent some cancer, in the case of colon cancer, or we can detect them early. That's the goal, right? So surveillance for cholangiocarcinoma and gallbladder cancer should be performed every year with imaging plus last serum CA19-9. As far as imaging, the guidance document recommends MRI-MRCP as the preferred test because it's more sensitive and it can detect lesions early. There's a recent study from the Mayo Clinic that shows that patients who are under surveillance are 5 times less likely to have events related to their cancer. This surveillance should start at age 18 because we very rarely see this type of malignancies in the pediatric population. And it's not needed for patients with small duct PSC unless they progress to large duct disease. Every time an ERCP is performed, we should obtain samples from the bile ducts to do cytology and FISH, which is a genetic testing that can indicate lesions suspicious for malignancy. Cholecystectomy, which is removal of the gallbladder, is considered if gallbladder polyps are greater than 8 millimeters. Now, smaller polyps also require monitoring, and that can be done with an ultrasound. It's interesting that we observe sometimes a small polyp, like a 4 millimeter. We see one time when we repeat 6 months later, that polyp may disappear. So the smaller lesions are unclear, but we should monitor them more often with an ultrasound, maybe every 6 months. If there is growth, then for sure this patient should also be referred for cholecystectomy. In the presence of cirrhosis, it's recommended that we perform surveillance for liver cancer as well. And as is recommended for hepatocellular carcinoma surveillance in other populations, this should be done every 6 months. And in the presence of inflammatory bowel disease, a colonoscopy is recommended every 1 to 2 years, starting at age 15. Okay, one important question for our patients with PSC, it's always to determine when should we obtain an ERCP. We understand it's an invasive test. It carries risks, right? Pancreatitis, bleeding. So we want to make sure that we don't do it unless it's necessary. Bacterial cholangitis, when it's not responding to treatment, for sure is an indication for an ERCP. And also when we have to evaluate a new relevant stricture, new symptoms, or worsening in the laboratory tests. Very often an MRI-MRCP will be required prior to the ERCP to define the roadmap and show the endoscopist what are the areas at risk that need to be evaluated. Antibiotic prophylaxis is indicated for 3 to 5 days. And if stents are placed, this should be removed within 4 weeks. That's something patients should know. Sometimes a stent is placed and 3 months later, 4 months later, they still have this stent when it's done by somebody without a lot of experience in PSC. So you know this should be removed because when they stay for a long time, there is an increased risk of cholangitis. What about liver transplantation? Well, this is considered for all patients with PSC and end-stage liver disease, some patients with intractable itching are candidates, and those with recurrent bacterial cholangitis. Early cholangiocarcinoma can also be an indication in specialized centers. Recurrent PSC, though, can occur in up to 40% of the cases and may progress to end-stage liver disease, again, requiring retransplantation. I'm going to spend a minute on cholangiocarcinoma. That's also addressed in this guidance document. So what is cholangiocarcinoma? That's a cancer of the bile duct, and that is classified according to its location, where the cancer develops. It can be distal in the bile duct, it can be at the bifurcation or perihilar, or it can appear inside the liver intrahepatic cholangiocarcinoma. Here I show you the risk factors for cholangiocarcinoma, with the ones appearing in dark red representing stronger risk factors. And you can see PSC is a risk factor for cholangiocarcinoma. The diagnosis will vary according to the type of cholangio. CT or MRI will be required to better evaluate the mass, vascular invasion, or presence of metastasis and resectability. CA19-9 alone should not be used to diagnose cholangiocarcinoma. Histology will be required to confirm your diagnosis. Now, your doctor may also order a CT or MRI of the chest, as this is important for staging, determining how advanced the tumor is. For perihilar and distal cholangiocarcinomas, ERCP with brushing should be obtained, right? However, if a patient is a candidate for liver transplantation, we should not obtain a biopsy of the mass through endoscopic ultrasound to avoid seeding. If they're lymph nodes, this can be sampled. And finally, as far as treatment of cholangiocarcinoma, this will also depend on the location of the cancer. The message here is that if it's early, then surgical resection is possible. For the intrahepatic, we can do that in about 40% of the cases. Liver transplant is not recommended for intrahepatic cholangio unless it's a research protocol. For perihilar and distal cholangio, you can resect if it's very early, and if the patient is a transplant candidate, it can be done with neoadjuvant chemoradiation followed by liver transplant, which is the so-called Mayo protocol. In both cases, patients should be in a center with expertise in hepatobiliary malignancies. But if the cancer is diagnosed later on at a more advanced stage, of course, there is chemotherapy. And I want to finish this with a glimpse of hope here, because as we develop our knowledge, as we find new mutations associated with these cancers, there is new targeted therapy that can be developed. For instance, for tumors with FGFR2 fusions, pemigatinib is now FDA approved. So I'm going to conclude here and answer your questions. Thank you so much.
Well, I want to thank all of our speakers for sticking to time, and we have a good half hour available for questions. Raj, I'm going to ask you first. You did a wonderful job in the chat room answering a number of questions that were raised to you, but I don't suspect that many of the people attending were reading the answers and questions in the chat room because they were trying to pay attention to the speaker. I wonder if you could summarize a couple of the key points that you were making in response to questions. And I'm going to ask you one other one just to be a little difficult. The current proposed guidelines, because again, these are not official, strongly urge non-invasive testing and imaging to determine the severity of the disease and the diagnosis, particularly looking at severity of disease. Yet they strongly oppose using the same test once the patient has eliminated, be it the virus or be it well-controlled PVC, using the same test to look for improvement in the same problem. We all know that hepatitis C is well shown now to reverse when it starts out at a lower level and even significant fibrosis over time with improvement in liver histology based on biopsies. Why are the tests not useful to follow patients long term to make sure that they have improved and stay improved?
Right. So well, thanks, Doug, for that question. And then later on, I'll summarize some of the questions that have been asked. So the problem with following these patients who had SVR and using that information reliably is that, when patients present with hepatitis C, there's a combination of inflammation and fibrosis that can lead to a certain degree of stiffness. And in the clinical trials, at least early on, the fibrosis assessment was made post SVR within the first 12 to 24 weeks. And then saw a decreased stiffness, but does that translate to an improvement in fibrosis, or the decreased stiffness is because they lost their inflammatory component and have just fibrosis? So that's where the challenge is. So I believe if you do a liver stiffness assessment immediately post SVR, a drop in the stiffness assessment, it would really could be just from a decreased inflammatory component. And the next thing is that you might get a little complacent if you were to use long-term fibrosis assessment with non-invasive tests where it's decreased. But then there still is cancer that pops up in these patients. So I think for that reason, again, until we see robust data as to what this decreased stiffness means or long-term, we want to use caution in using that data, because these patients still remain at risk for cancer, and we've seen that even after they have a decreased stiffness. So that's the way I see it. Now, in terms of summarizing the questions mostly been in the area of sarcopenia and frailty. One is an interesting question: should patients and caregivers demand an assessment of sarcopenia and frailty? I thought it was interesting. Yes, if indeed it's not being done, it really should ask for it to see where they stand. But more importantly, advise on their nutrition in terms of protein intake is the most critical, I feel, apart from exercise. So clearly that should be a component of our assessment of our patients with cirrhosis. And then the importance of nighttime snack and early breakfast. Again, I've emphasized people do appreciate the importance of that. And again, the importance of not restricting protein. That's been something that's been done previously for hepatic encephalopathy years ago, said restrict protein. So at least some of the recommendations were made along those lines, but clearly it's not to be the case.
Thank you very much. I want to stress the point that you agreed with again that Fred Jolin made, that telling patients that they should get so much protein a day, many of them who have been on a strict restricted protein diet will run right out and get a 1 pound steak for their dinner. And that's not really what you're talking about. And I think we all understand that, but I think the patients need to understand it doesn't mean just go out and get a triple burger or whatever. It's to space it out over the course of the day. I have a question quickly for Cynthia Levy too. I noticed that the new guideline as you presented it for PBC makes no mention of obeticholic acid, even though it's FDA approved in patients who have not adequately responded to ursodeoxycholic acid. Would you comment on that?
Yes, Doug, thank you. I presented the guidance document on primary sclerosing cholangitis, and obeticholic acid at this time is approved for primary biliary cholangitis, which is another disease involving the bile ducts, but it's not approved for primary sclerosing cholangitis. So it is not addressed in the current guidance document.
Okay, thank you.
Sure.
Questions?
I'm also getting questions here in the chat about recommendations for fat-soluble vitamin deficiency testing, DEXA. This will all be in the guidelines. We didn't have time to address everything, but we do recommend DEXA scan at baseline, so at the time of diagnosis, even though it's controversial and there is no randomized control data or meta-analysis data for that matter to suggest, but the frequency of metabolic bone disease is increased in our patients with cholestatic diseases, including kids. We all have 18-year-olds with IBD and PSC who also have metabolic bone disease and even osteoporotic changes. So we do that at baseline, and then the follow-up will be depending on what we find in that initial test. And there's, as far as fat-soluble vitamin deficiencies, we don't have to test it early if the patient doesn't have advanced disease, but so for patients with more significant cholestasis or bilirubin elevation, that's when we start checking for vitamins A and E deficiencies. Vitamin D deficiencies levels are checked at the baseline as well.
And Dr. Levy can ask one more question. I understand very well the strong recommendation for MRI, MRCP studies, but starting at age 15 yearly, or even more often in those that appear to be progressing or not responding, would you discuss the concerns about risk of exposure to imaging agents, et cetera, on that frequent basis for what could be 20, 30, 40 years?
Yeah, so those are all good points. And we have to balance these recommendations against the stress of knowing that the risk is increased and not doing much about it, right? So as far as MRI, there may be new contrasts that are being studied that hopefully will have less problems of accumulation in the brain. For instance, that's one concern with gadolinium.
Right.
But at this point, MRI is still the recommended test. You can do ultrasound and CT scans as well. MRI is more sensitive. If you do CT scan, then you have radiation. If you do ultrasound, you may not be visualizing the entire liver and you may miss lesions, smaller lesions, right? So we have to juggle with this. But it's a good point. There was an abstract presented, actually, it was an oral during this meeting with data from Sweden, where they see that the incidence of cholengia is still so rare that when you follow your patients for a long period of time, you may not even detect, it may not be worth it with the MRI. There was one study from Sweden showing that, from Anika's group. But at this time, especially given data that came from Mayo Clinic, as I mentioned, showing very clearly that patients who were under surveillance were diagnosed earlier, they were more likely to have a curative procedure done, either transplant or surgery, and 5 times less likely to have complications related to the cancer. Based on that, the group decided to recommend, and this is also going to be endorsed by the European guidelines.
Yeah, I see Fred Golan has raised a question about a PSC breakout group during this meeting failed to find and detect curable cancers with MRI.
Yeah,
in a multi-center study. And given the cost of that, and I'm wondering how regularly insurance will pay for it with repeats. That's often a problem.
Not in starting at 18 is what is the recommendation. The colonoscopy starts at 15. But that's one hope. By including these recommendations in guidelines, we hope we make payment easier, approval easier by the payers, because they will be supported by our societies.
I hope you'll be talking to the payers. Thank you.
Sure.
Any other questions that are unanswered so far? You can unmute and ask a question. You can raise your hand. You can type it into the chat. Question about when you would stop Ursodiol after 6 months in PSC patients. Stopping rules.
The question is, if we start Ursodiol in PSC, is there any stopping criteria after 6 months? No, it's our relationships with the patients and explaining the data or the lack thereof. It will be very individualized. The guidance document proposed 6 months based on some data in an editorial by Keith Linder and James Tabibian a couple of years ago. So giving 6 months to see if there's improvement in labs and symptoms. And if not, it can be stopped. But if you decide to go beyond that, and at a later point, still think that there's no benefit, you can stop it at any time, right? We should not be using ursodeoxycholic for its chemopreventive abilities because that has not been confirmed. And it's my personal bias also to always refer patients or at least mention to them that there are so many clinical trials available and coming up. And without those, we will not identify therapies that can really change their outcomes, right? Including vancomycin, which we mentioned there is insufficient data. Currently, there is a randomized controlled trial that is enrolling patients for that study. So we encourage patients to enroll.
Thank you.
I would like to, when we spoke of sarcopenia and frailty, I think that's a big fear that many patients have. And first of all, thank you to Doug. Thank you for inviting me to moderate this with you and to this wonderful, distinguished panel. And it was very dense and very comprehensive. And I'd like to point everyone to that Nutrition 101 class that was held yesterday, I believe after the 20th, it'll be available. And it was some of the best slides that I've seen about diet, nutrition, malnutrition, and protein intake for patients at all stages of liver disease. So again, thank you guys for all these great questions, but I wanted to point to that great webinar that we had yesterday. Great meeting.
I came across a question from someone who was a late joiner, and I think this would be for you, Raj, asking if you could, if TLF was discussed and your opinion on that.
Actually, hi, my name is Roma Levy. I'm the person who posted that question, and I will give full disclosure here. I'm the clinical expert for liver disease at Siemens Healthineers. We are the manufacturer of that test. And I realized in listening to the discussion that this is actually a discussion only about things that are currently in the AASLD guidelines. And ELF is more likely going to show up in the coming guideline rather than actually be in the guideline right now based upon the CLDF interim clearance. But I do want to point out that this test has received de novo authorization based upon this breakthrough device determination from a couple of years ago, and will be available for use by hepatologists and endocrinologists probably first around mid-December, mid-January timeframe. It is a very powerful prognostic test for patients who have either bridging fibrosis or cirrhosis. And I don't want to make this a marketing pitch, so if you do want more information on it, please don't hesitate to send me a message or drop by the Siemens booth to find out more information.
Thank you for that clarification. Are there any more questions? We still have time if people have questions. I noticed that our almost 90 attendees has now dropped down to 41, but we're happy to stay here for those that are still on if you have more questions before we lose our experts moving on to their other assignments at this meeting and you moving on to other sessions that you're anxious to get to. Going once. Going twice. Well, I want to thank Karen for all her hard work on this session and for all her many contributions to the Liver Society as an advocate. She was a perfect example of a patient who has survived tremendous problems. And someday, if you get a chance to hear her story, I think you'll be amazed. And she's taken that to recognize the lack of information out there and the confusing information out there for patients on the internet. I mean, there's tons of information on Google and the internet, but so much of it is incorrect, that to have reliable sources for patients written for patients, not written for scientists and MDs, and there are special language, if you will. She's contributing on several committees now at the AASLD to try and improve things for patients. And I'm delighted to have had her work with me and help me on this. And I thank you all once again. I thank Mike and Mike Provenance and Julie for all their help to get this together. Any other final comments from anybody? Well, have a good meeting, everyone, and thank you so much for joining us.
Thanks, everyone,
Right.
for attending.
Bye.
Thank you, Doug. Thank you,
Bye.
team.
Thanks very much.
Thank you.
Bye, thank you.
Our speakers especially, thank you.
Yes.
Thank you, Doug.